I will discuss with you today three topics. One is to understand the most common bone marrow edema-like syndrome. We say edema-like because bone marrow edema is not only edema in the extracellular space, so we prefer to use this terminology. Then to understand why in some young adults we have early osteoarthritis, although there is a lack of history of previous trauma or infection. And also I would like to discuss with you the extra-articular impingement syndromes. So the bone marrow edema syndromes include the well-known transient osteoporosis or transient bone marrow edema syndrome. It's the same thing. The advanced avascular necrosis, which is related to bone marrow edema, and the stress fractures. The edema, which is associated with inflammation, infection, and neoplasia, will not be discussed today because we don't have much time. So in the late 50s, transient osteoporosis was described by Curtis and Lacade in women in the third trimester of pregnancy or right after delivery. But then we found out that mostly transient osteoporosis is seen in middle-aged men. This is an idiopathic and self-limited disorder with a sudden onset of hip pain, no injury in the history. Usually it lasts between 6 and 9 months, and the histology never shows osteonecrosis, so it's completely different entity. Plain radiographs in the beginning, after the onset of symptoms, are usually negative. In 3 to 4 weeks, we may see osteopenia, and sometimes the findings are very subtle that we have to be very careful. For instance, in this 40-year-old male, we see with right hip pain joint, we see that we have lost this cortical outline of the femoral hand. This is the earliest finding of osteopenia. On the other hand, MR imaging shows very nicely the bone marrow edema and very quickly after the onset of symptoms. We believe in a few hours, but in most cases, after 48 hours, the bone marrow edema is obvious, and it's demonstrated with low signal on T1, high signal on fat-suppressed images, and homogeneous enhancement after gadolinium injection. Transient osteoporosis also shows the so-called sparing sign in the majority of cases. This sparing sign in the anteromedial part that we see in normal bone marrow is related to the microtrabecular architecture in this area, where the thick network of trabecula do not allow the bone marrow edema to expand anteromedially. The same is also true in the area of the greater trochanter. In addition, almost always we have synovitis in these patients. That means fluid joint diffusion with some thickening of the synovium and contrast enhancement. In half of the cases, we see these low signal intensity lines, irregular lines in the deep subchondral area, which are thought to represent reversible insufficiency microtrabecular fractures. They are not clinically important. This is another case with homogeneous enhancement. I think I need the paper just because it's the surface is very slippery. Oh, thank you very much. Hope it works. Here, thank you. This is homogeneous enhancement. Bilateral demonstration of bone marrow edema almost always occurs in pregnant women or in women right after delivery. I've seen only one case in a young adult man with bilateral transient osteoporosis. Here we see bone marrow edema on the right side, bone marrow edema on the left side, also a small insufficiency fracture in the subarticular area. You see the enlarged uterus right after delivery. Let's move now to the regional migratory osteoporosis. About 1 decade later than the original description of transient osteoporosis, Duncan described a similar arthralgia or a similar syndrome, which is characterized mainly by migration of the painful arthralgia. Later on, we found out that X-rays, scintigraphy, clinical findings, and MR imaging are similar to transient osteoporosis of the hip. And we cannot predict actually at which interval the migration will occur. Our team has found out that regional migratory osteoporosis usually is seen in males, and also in patients with transient osteoporosis, the risk of progression to regional migratory osteoporosis is 1 in 1 out of 5 patients. Here is an example. We have original location of the bone marrow edema on the right side. Then moving to the left, there is a resolution of the edema on the right side. And later on, in the right knee, medial femoral condyle. But involvement of the hip may also be later in the course of the disease. For instance, here we see in another patient, 35 male, medial femoral condyle, then it's gone, then lateral femoral condyle, and then hip. And in these patients, we have seen that if we do spinal DEXA, we see osteopenia or osteoporosis. So probably there is enough indication now in the literature that RMO, or regional migratory osteoporosis, is related to a systemic underlying osteopenia. Moving now to the avascular necrosis. Avascular necrosis in the early stages is completely asymptomatic. In stage 1, the radiographs are completely normal, and MR imaging shows this band-like zone, the low signal intensity irregular line in the subchondral area, which is pathognomonic for osteonecrosis. There is no edema in these states. In stage 3, in most of the systems, either ARCO or Steinberg's, we have advanced osteonecrosis with the presence of the so-called crescent sign. The crescent sign is a subchondral fracture, as you see here. And this subchondral fracture is related to bone marrow edema because of the advanced disease. On the left side, you see also band-like. You see a small osteonecrotic area, no bone marrow edema. Therefore, the presence of the crescent sign, the subarticular fracture, together with early collapse of the articular surface, is related to bone marrow edema, as we also see here. Flattening of the articular surface, the osteonecrotic area, extensive bone marrow edema, articular collapse, as we see here. This is an advanced stage, and it's treated with total hip arthroplasty. In general, pain in patients with avascular necrosis is related either to advanced disease because of articular collapse and bone marrow edema, and or presence of joint fusion. Moving on to the injuries now, we have the fatigue and the insufficiency fractures. The stress reaction represents the earliest phase of stress injuries. It's shown as an area of bone marrow edema without the presence of any fracture line. Stress fractures or insufficiency fractures occur when we see this low signal intensity line extending up to the cortex and surrounded by bone marrow edema. Sometimes these injuries are quite challenging in the clinical everyday and routine praxis. As we see here, this 58-year-old male, an athletic one who is playing tennis, who goes to the gym, has a history of prostatic carcinoma, presents with pain in the pelvis, but this is an important information from the history. There is pain relief with rest. Bone scintigraphy suggested metastatic disease, and MRI shows many areas of bone marrow edema representing stress reaction, and another one with low signal intensity line extending to the cortex, which is a stress fracture. With just rest, this patient had a full recovery in 3 months. The second topic today will be early osteoarthritis. I think this is a very important one. It's usually quite difficult for those who are not familiar, and we need always to explore which is the underlying condition which contributes to the presence of early osteoarthritis. So femoroacetabular impingement is the one topic, subclinical developmental dysplasia is the second one, and the presence of traumatic labral tears the third. So we all know that the femoroacetabular impingement is related to a reduced femoral head-neck offset, this bony bump here. This is the CAM-type femoroacetabular impingement, or to excessive overcoverage regardless of its cause. We can have also a mixed type. So normally the flexion and external or external rotation of the lower limb does not induce any abnormal contact here. We have normal articular surfaces, no abnormal contact. With the CAM-type impingement, you see the clinical test here that we check the presence of CAM-type. We have the bony bump abutting on the lateral edge of the acetabulum and causing labral degeneration or tear or delamination of the cartilage. With the pincer type here is the clinical test that we are assessing the presence or the absence of this syndrome. We have also, because of the overcoverage, abnormal contact. But with the pincer type, the osteoarthritis is usually less severe. With CAM type, it's severe occasionally. So with the CAM type, the CAM comes from the engine. We have an abnormally shaped femoral head, we see it here. Normal acetabulum, and with flexion and internal rotation, we have abutment of this bony bump over the acetabulum, and the cartilage may fully delaminate. This is also known as pistol grip deformity because of this particular appearance on the plane films, which are similar to the pistol grip. We see this guy, 35-year-old, kickbox, elite athlete. We see joint space narrowing here, and early osteoarthritis also on the right side. This is the natural history of CAM femoroacetabular impingement. If there is no prompt diagnosis and proper treatment, then we may have early osteoarthritis, as you see in this 29 only male athlete who is involved in martial arts. You see the pistol grip deformity and the extensive joint space narrowing with sclerotic and cystic formation subarticularly, in keeping with advanced osteoarthritis. Now there is no field for treatment. This athlete should be treated 5 to 10 years earlier. And this is another athlete. We see that there is advanced osteoarthritis with geode formation surrounding bone marrow edema, labral tear, also on the right side, extensive osteoarthritis at the age of 39. MR arthrography, which will be addressed later on by Jenny, is the best way to go for early detection of CAM-type impingement and its consequences. Here we see the bony bump, which is projecting, and in particular views we see the labral tears without any cartilage delamination. There is a lot of discussion about alpha angle. I would like also to listen to Jenny's opinion on that later on, but I'm not relying on this very much. There are papers which suggest that 55 degrees is the upper normal limit. Others, more recent, said that 78 degrees would be the upper normal limit, a paper published recently in Cartilage and Osteoarthritis. But in my view, alpha angle is just an indication. In elite athletes, we may have findings with an alpha angle of 55 degrees or even 50, whereas in in a guy who is lying on the sofa drinking beer all day, not being involved in sports at all, then even an 80 degrees alpha angle is not clinically important. So the alpha angle is measured on oblique axial images on MR, either plane or arthrographic images, and it's also easy to detect, to measure it on plane radiographs. Moving now to developmental dysplasia, this is an entity that has not been discussed or explored widely in the literature, particularly in its subclinical form. This is also a type of impingement because of the abnormal contact between the femoral head and the acetabulum, resulting by this subluxation. So developmental dysplasia has been shown in the literature that it's responsible for 10% of all total hip replacements. And we see this in up to 30% in patients under 60s, and we see in up to 50% in patients under 50 years old significant osteoarthritis. Therefore, it's clearly related to osteoarthritis, but not in the way that we know developmental dysplasia. Now it's almost obsolete. We are talking about this subclinical, which is a minor, let's say, developmental dysplasia of the hip, which has skipped the clinicians. So normally, we have a very nice and equal distribution of the loading forces between the femoral head and the acetabulum. But in developmental dysplasia, you see that there is not an equal distribution. The weight-bearing surface is quite smaller, and therefore, in the beginning, because of this asymmetric loading, we have a swelling of the labrum. That's the first reaction. This is very typical of developmental dysplasia of the hip, and later on, we have a torn labrum. So a very easy way to assess the subclinical developmental dysplasia is to measure the Weiberg's or the center-to-edge angle, which has been used a few decades ago. So from the center point of a circle of the femoral hand, we draw a line perpendicular and one up to the edge of the acetabulum. This angle should be normally more than 25. If it is between 20 and 25, then this is the subclinical form of developmental dysplasia. If it's less than 20, then it's an overt form of developmental dysplasia. For instance, this is an Olympic-level athlete in Greco-Roman wrestling with painful hip on the right. We see that there is an abnormal CE angle, and MR imaging shows labral tear with paralabral cyst formation and joint space narrowing anterosuperiorly and posterior-inferiorly, together with osteophyte formation in keeping with early osteoarthritis. In another athlete, MR arthrogram, 25 ballet dancer, we see the abnormal CE ankle and the development of osteoarthritis with huge zeod formation within the acetabulum, which is filled with contrast because of communication with the joint space. Therefore, early osteoarthritis at the age of 25. Another example, a surgeon in our area, 58, athletic, but always he mentioned problems with the hips. We see that both hips show abnormal morphology with shallow of the acetabulum weight-bearing surface and also some subluxation of the femoral hands. We see on MR arthrograms the typical finding of swelling. As you see, we have enlarged labra, huge labra. This is pathognomonic of developmental dysplasia, and also a labral tear. Labral tears have been also considered to be one cause of early osteoarthritis, not as important as the camp type femoral acetabular impingement or the developmental dysplasia of the hip, but it seems that there is indication in the literature that a long-standing labral tear contributes to early osteoarthritis. So normally the labra have a triangular shape, low signal intensity. Here is an elite windsurfer with a single traumatic event. Labral tears occur usually with a single traumatic event, whereas in camp-type femoral stabular impingement and developmental dysplasia because of repetitive abnormal stress. Here we see a labral tear and another one in a track athlete, long jumper. The third and last topic today in this morning lecture is the extra-articular impingement syndromes. From these, the ischiofemoral one is related to gluteal pain, so we will not discuss this today. We will discuss the ones who are related to pain around the hip joint, the iliotibial friction and iliopsoas tendon friction, which are also called snapping hip syndromes. The iliotibial band impingement syndrome belongs to the group of disorders which is called under the umbrella of painful greater trochanter pain syndrome. This is demonstrated on MR with edema in between the iliotibial band and the greater trochanter, or fluid, as we see here. The discrimination between fluid and edema is important, and we'll discuss in a minute why. So in general, pain in this latter aspect has to be also differentiated from other disorders. So we have always to consider rheumatologically caused or induced bursitis, like in rheumatoid arthritis, gluteal tendinopathy such as degeneration or tear, and also hydroxyapatite deposition disease or calcific tendonitis as it is known usually. So in general, developmental dysplasia and coxa-vara are predisposing factor to iliotibial band impingement syndrome. Here we're seeing two patients, presence of bursa, fluid. Fluid is important. We have shown in a recent paper that the presence of edema alone is clinically usually irrelevant, and it's seen very often in middle-aged and elderly women, whereas the presence of fluid is clinically important. And we have also to consider that in the snapping hip syndrome, we may see also bone marrow edema as a reaction to the snapping of the iliotibial band. But in a number of athletes, it seems that it may be completely asymptomatic. So we have to carefully match the symptoms and the MR imaging findings. The internal type or anterior type or coxa saltans impingement is the one which is related to the abnormal course or contact or impingement of the iliopsoas tendon. This can be quite often painless. In 10% of patients, there is a sound. The clinician can feel the snapping in the anterior part of the hip joint, but there is no pain. It's seen mostly in runners and dancers, and here we see the typical finding with abnormal edema in the course of the iliopsoas tendon, which occasionally can be related to labral tear or bone marrow edema, as we see here. So overall, we discussed today the various phases of bone marrow edema in the group of adults, young adults and middle-aged adults, with particular reference to transient osteoporosis of the hip. We try to explore why early osteoarthritis may appear in this age group, and this is related mostly to camp-type femoral stabular impingement and developmental dysplasia of the hip. And in the end, we discussed briefly the extra-articular impingement syndromes. Thank you very much for your attention. Now I think we have the second part. I have another file. Can you please upload that? Which is related to some kind of interaction.
Entonces les recuerdo que aprovechando nuestra red de Wi-Fi en el hotel puedan descargar la aplicación CIR 2017 a través de la cual pueden participar en la sesión interactiva que vamos a tener en cada salón, y el doctor Carantanas nos va a presentar ahora algunos casos con preguntas interactivas para que ustedes puedan participar.